Support for this podcast comes from iTube.net. iTube is ophthalmology's leading source for high-quality ophthalmic surgical videos, educational series, spotlights, and more. Visit iTube.net or follow us on Instagram at iTubeNet.
As much as we've learned about ocular surface disease, there is still so much yet to be discovered. The good news is, this creates a world of opportunity for eye care providers.
The goal of this podcast is to better understand this chronic and complex condition and keep you up to date on the advances being made in its diagnosis and treatment. So let's get to the point. Welcome to another episode of the To The Point podcast. My name is Jackie Garlich, and I'm joined by my co-host, Jessilin Quint. Hello, Jessilin.
Hello, Jackie, and hello to all of our listeners. It's 2025. Here we go.
I know. Here we go. And let me tell you something that I don't want to miss in 2025. Well, maybe that's not the way to say this. Well, sometimes when I'm seeing a dry eye patient, and Jessilin, I would assume maybe this happens to you sometimes. Do you ever wonder, like, am I missing something bigger here? Like, is there some stuff is not lining up for me? Like, why is this patient not getting any better? Is there something that I'm overlooking or I haven't thought about or something systemic that I need to think about? That's what we're going to talk about in today's podcast. And we brought on like the best person to talk about this because he's got an amazing lecture about all of these dry eye masqueraders. So Jessilin, tell us about our guest today.
Yes, we have Dr. Mile Brujic, who is I would say, dry eye innovator. By day, he does so many amazing things, but is a guitarist and a total music enthusiast by night. And if you've ever been on a Zoom call with Mile, just as we are watching him now, he has this beautiful background of guitar. So off this podcast, we might have to pick your brain on your guitar collection because it looks pretty amazing. But getting back to Dry Eye Masqueraders, he owns his practice in Ohio Premier Vision Group. He is an avid lecturer. I think he's probably given thousands and thousands of lectures, both internationally and nationally. And anytime you're around him, even in just casual conversation, I know I always walk away with a clinical pearl. So I'm really excited today to hear how he can just, educate us on all of these dry eye masqueraders, because we definitely do not want to miss these in 2025. So Mile, thank you so much for being here. It's a pleasure to have you.
Thank you guys both for having me on the podcast. Really, really appreciate it. I'm looking forward to it.
Yeah, let's start us off. I mean, you really, I have asked you these questions before, but can you talk a little bit about, well, I mean, I think this whole idea actually stemmed off of this lecture that I know you have on like these dry eye masqueraders. And this is something I'm always like fearful of, like, am I missing something else or something deeper that I'm not thinking about? And what are some of the most common masqueraders you see? You're getting patients referred into you for dry eye. Presumably these patients aren't, improving with whatever therapy they're on. What is the most common thing that you're seeing that we're missing when we're treating a dry eye patient?
Yeah, Jackie. So it's interesting because there's so many things when you don't put all the pieces of the puzzle together that can sound very, very similar to dry eye disease. This stemmed years ago. It was about 20 years ago. I just became a partner of the practice that I'm in right now. And I had a patient who came in the office, 42-year-old female. I used to describe this person as an older 42-year-old female. I'm 49 years old now, so I describe her as this young, hip 42-year-old female. But she came in, I prescribed her first pair of progressive edition lenses. She came back a month later complaining that she couldn't see out of them. When I actually kind of did a little bit of a deeper dive, I realized that she had fluctuating vision. I put fluorescein on the eyes and I identified this individual as having dry eye disease. And I realized at that point how important it was to identify dry eye in the exam room. And what we kind of do as there's several tools that we utilize, but one of the tools that we utilize is literally fluorescein on the eyes. And we realize that we can see so much about the ocular surface when we do that. Saying that, we've also realized over the last 22 years that there's a lot of things that masquerade as dry eye. And one of those things that we started seeing very, very early on was epithelial basement membrane dystrophy. These are patients who will complain about fluctuating vision in a little bit of a different way. They complain about fluctuating vision, sometimes having days that are better vision versus other days. And literally putting fluorescein on the eye gives you the ability to see these islands of negative staining that are literally invisible when you don't put fluorescein on the eye. So the way that you treat these patients may be somewhat similar, but the way that you communicate about the condition is absolutely 100% totally different. And that's just one example of several that can masquerade symptom-wise very, very similarly. One of the things I'll share with you in one of my favorite cases was patient who came in, and they came into the office with blepharitis and a mixed blepharitis dry eye symptomology, and they were on several medications. And as soon as I literally touched the patient's lid, I could tell that this individual had floppy eyelid syndrome. I confirmed it. I tried to avert the upper eyelids, and certainly they averted very, very easily. But all I literally had to do was keep that patient's eyes closed and covered in the evening, and I knew I'd make that individual better. So, in an instance where this person was using warm compresses, medications for meibomian gland dysfunction, medications for dry eye, we took this person off everything. But we also had to have a secondary conversation. And that secondary conversation revolved around the fact of, hey, do you snore in the evening? Do you have any trouble sleeping at night? Do you ever feel unrested? And the answer was yes to all those questions. So this was a young man. He was 30, 32 years old, and he had all these symptoms and they were unresolving. So I not only fixed his immediate problems, but I also identified this systemic condition that he had. So this is so important that as we start hearing these symptoms that align so closely with dry eye disease, we're identifying these other conditions to make sure that we're treating those patients appropriately, and also making sure that when there is a systemic link associated with it, we're making that link.
You already gave some great examples. EBMD, floppy eyelid syndrome, there's a lot more masqueraders. Do you, or because I know you work with students too, or docs you're bringing on your practice, or other clinicians who are just wanting to learn, what are like your immediate red flags that you look for? Like, do you have kind of like a protocol or a checklist that you kind of run through in your mind to make sure that you're not overlooking any of these masqueraders?
Yep, I'm so glad you asked that question because some of the things are like things that we all do on a standard slit lamp evaluation, but there's a few other things that I've added throughout the years that help me distinguish these things. So first, whenever I see a patient, before I'm evaluating them, I actually pull their lower eyelids down just with my fingers without looking at the slit lamp. And when you do that, you can actually see a patient's meibomian glands. So you start to see whether or not there are any shortening of the glands that are present. But you also get an immediate feel of what the elasticity is on the eyelid margins. And then what we also started doing is anybody complaining about any dry issues, and certainly those patients who have symptoms that are more prominent in the morning, I actually check for adequate lid seal. So you just literally take an eye transilluminator, you put it on the outer third of the upper tarsal plate, shine it down through that tarsal plate where we don't expect to see any light coming through that space between the upper and lower eyelid. And if we do, that suspicion of some type of exposure in the evening, even in the absence of any type of frank exposure, because we know that when that lid seal is inadequate, we just need to go a different route than a standard dry eye and realize that all of this can be concurrent with dry eye disease, but we need to make sure that we're identifying these things so that we can appropriately treat these patients. And then on every single patient, every single individual, I put fluorescein on the eyes before I put them at a slit lamp. And I view them with the cobalt blue light and a rat number 12 filter. What I've seen on the ocular surface that's absolutely invisible without fluorescein and a rat number 12 and a cobalt blue light is remarkable. There are things, again, that we cannot see them unless we put those vital dyes in the eye. So it's just become a process of my standard eye exam. And the amount that I've just uncovered through that one little step has been tremendous. The other thing that I think we kind of always overlook, and it's a lack of sexiness in eye care, is taking a very, very close look at the eyelid margin. So what I have all patients do is have them look down, looking very close at the eyelashes and the base of the eyelashes for the presence of collarettes. But in addition to that, I flip the magnification up on the slit lamp, And those two steps, along with just pulling any type of dermatochalasis up, will expose any type of collarettes that may be present at the base of the lashes. So these all help uncover these symptoms that will masquerade very, very similarly to dry eye. One of the other things that I want to do as well too, and I always want to make sure that whenever we're talking about caring for the patient holistically, is that we're looking at them without the slit lamp as well too. So we expect everybody to have a certain amount of lid coverage of the vertical visible iris diameter through the presence of the upper eyelid. And it's when we start seeing scleral show or a difference in appearance between the two eyes that we start even suspecting things like thyroid eye disease that we talk about a little bit, but those things will manifest symptoms early on, very similar to dry eye, just because of exposure issues. So when we can identify those, we can get those patients to appropriate testing and appropriate treatment as well, because now we know that we have a intravenous infusion that is approved to treat thyroid eye disease patients as well. It used to be an archaic treatment where you used to have to go into the retrobulbar space, and now you can do it with, again, with an infusion.
I'm so glad you said that about thyroid eye disease, because that was going to be my next question for you is at what point, and how are you differentiating? We see inferior corneal staining, and I think a lot of us will say, oh, this is an incomplete blink here, and this is incomplete lid seal that we're seeing, or lag ophthalmos. And there is this sort of like, well, yes, but is it also maybe related to an underlying thyroid disease? So I'm glad you brought that one up, because I do think that one can sometimes that can go past us without giving a reason for maybe why we're seeing some of that, incomplete blink or that lag ophthalmos. It sounds like a lot of the things you're doing require no extra special testing. I mean, you describe visualizing meibomian glands without the use of a meibographer, which you absolutely can do. Is there ever a time where you're using something more advanced to really differentiate between X and Y? Or are you finding that really a lot of things you've got just in your regular sort of exam room without any extra diagnostic equipment?
We're starting to. We've kind of started evolving this conversation a little bit, because what is dry eye disease? Well, if you ask somebody, it involves and encompasses meibomian gland dysfunction as part of dry eye disease. You talk to other clinicians and they say, well, meibomian gland dysfunction is something that's a separate entity. Dry eye disease is X. So as we start identifying this a little bit more, so we start realizing that we can incorporate some of these tools and technology. Meibography is one of the ones that comes to mind immediately. But there are new tools that are helping us become even better diagnosticians from a kind of a more advanced approach. I'll give you a perfect example of what I mean. And it's the patient with the pain without, or excuse me, the stain without pain, which is the neurotrophic patient. These individuals are the ones that we're oftentimes treating for dry eye disease, attempting to put immunomodulatory agents on the eyes, attempting and re-encouraging these individuals to continue with therapy. But oftentimes these patients with stage 1 and stage 2, they really don't follow a lot of our recommendations unless we can very, very creatively make sure that they understand why they're noticing the symptoms that they are. So then we start to involve things like anterior segment imaging, which we have in every single one of our exam rooms, to help patients with anterior segment issues really understand why we're treating them. But one of the other cool tools, so the way that we used to test corneal sensitivity was, hey, let's take, a dental floss or a cotton wisp and see if the patient can feel it on the cornea. We've recently incorporated the Brill aesthesiometer. So what this literally does is it shoots a quantity of air at the cornea at a very given concentration, and there's 5 different levels. Level one is the weakest level. Then it keeps increasing to level 2, 3, 4, and 5, where level 5 it's a stronger puff of air, but it's still a fraction of what happens during a standard non-contact tonometry puff. And all the patient tells us is, yep, I feel it, or no, I don't feel it. So that individual who you're at a 4 or 5, we don't expect somebody not to experience some form of sensation at that level of air against the cornea. Level 2 and 3, that's where we expect most individuals to say, yep, I can feel it. And if somebody can feel it at level 1, we now know they're on the exact opposite level of the spectrum. And we know these individuals may be hypersensitive. And a lot of times for those patients that are non-responder to some of our therapies are those hypersensitive patients. And those corneal nerve endings have just become oversensitized. There's another test that we started incorporating relatively recently with our dry eye patients, and this actually helps manage patients' expectations better. We do the Preparicane test. Some individuals are doing this very, very regularly, others aren't. Last year, we started doing on every single dry eye patient who isn't responding the way that we would expect, or any new dry eye patient. And the way the test is performed is it's relatively simple. You ask the patient on a scale from 0 to 10, what do your eyes feel like? 10 is the worst dryness you can experience. 0 is the least dryness you can experience. And then we put a drop of Preparicane in the eye, wait about 60 to 90 seconds, and ask them the same response. Now, we would expect most dry eye patients to respond at a very, very low level after installation of Preparicane. There's a subset of patients who will get better, but don't go down to 0 or 1 or 2. There's a subset of patients who stay the exact same, and there's a subset of patients who actually get worse after Preparicane installation. Why that's important is because it gives us indications of some form of central etiology to the dryness that these individuals are experiencing. So although it's important for these patients to treat the ocular surface, we always have to become cognizant of the way that we're describing outcomes to these patients. So this was my second last patient today. So I told her, I said, we're going to start treating what I'm seeing on the surface of the eye, because that will eventually, I think, make this better. But there are going to be some level of limitation in terms of how you physically feel over time because of this central component. And the way I described it is, you were supposed to get much better after I put this drop in your eye, and you didn't. And because of that, we know there's a second, more chronic component to your dryness. And it helps patients understand their outcomes. I've had several patients who literally have cried in the chair telling me that, I'm so glad you told me this, and I'm so glad you did this test, because I always felt like I was crazy bringing up these symptoms, and patients or clinicians telling us that they don't see anything wrong. So there's this whole kind of world now around the patient perception, and things like the aesthesiometer that can now give much more well-defined, technologically reproducible levels of pressure along the cornea are going to help us understand much more about these patients over time.
I like that you use everything from like balling on a budget, right, to like the best of the best, the newest technology to really help your patients. And I also like that you really pointed out that we have to set a realistic expectation for our patients. And I think that that shows how important it is to identify those masqueraders, not only so that we develop the best management plan and treatment plan, but so that your patient also knows what to expect, right? Because if they have all these confounding things that might look like dry eye or feel like dry eye, but maybe at its core aren't dry eye, and you do, all the in-office treatments and all these different pharmacological agents, and they have this expectation that they're just going to be magically cured, right? That doesn't help anyone. And so being able to identify these masqueraders really early on and set that clear expectation, I think is really helpful for our patients.
Jessilin, I would even echo what you just said, because now we're starting to get into clinical paths of treatment that are they're costing patients real money outside of standard insurance coverage. And when we're talking about some of these more advanced treatments for traditional dry eye or things that can cause secondary dry eye, again, they're paying good money for these things. And as a clinician, we certainly want to make sure we're setting expectations as best as we possibly can. And we know that with dry eye, it's never 100% we can set those expectations. But the better we can, the better that everybody's going to be happy moving forward through this process. And it's just our little kind of way to figure this out on these individuals and help set that path better as we pursue some of these more advanced treatment options.
I'm glad you're mentioning the neuropathic patient that you're describing here, where the patient is complaining a lot about dryness, but the clinician doesn't see much. And these are some of the hardest patients to treat and to improve, particularly when they have that central component involved. If it's peripheral, they tend to respond a little better. Have you found therapies that work well for these patients? I mean, it's somewhat nuanced. There's a lot of studies on oral therapies to try to improve neuropathic patients, but have you found, this isn't necessarily a neuropathic podcast, but I'm just curious because it's such a hard person to really manage, if you found therapies that tend to work better for those patients?
Yes, kind of. And I
Yeah.
always put an asterisk beside this because this is the one place in eye care that we don't have anything that's FDA approved. So anything that we're sharing really doesn't even carry a lot of controlled trials outside of the FDA or within the FDA. So again, so we don't have a lot of those things. Things that we understand help though. Some of these patients are on antidepressants. We've found that some of these work, but that really requires coordination with their primary care doctor. I certainly don't want to be involved in prescribing some of these agents without the inclusion of their PCP, and also other ways that we could potentially strategize therapies. But when we're talking about the eyes themselves, there's two things that I describe to patients, and then I'll share with you exactly what we're doing for those patients now. The first is there's two nerves that control this, the one that innervates your cornea, and that nerve that innervates your cornea, even when we numb that or make it feel better, you're still feeling this. So we know this is centrally derived. But we know from the literature that if we continue to treat the surface of the eye, we hope that the central system will actually start firing less of that dryness symptom or eye pain symptom for you. So again, this is totally off label, but one of the things that we found some success with is varenicline nasal spray. And we think there is something in this neural feedback pathway between the trigeminal nerve endings within the nasal cavity where you're stimulating them. They're communicating to that trigeminal nerve centrally that's causing a recreation of the perception of that pain. We have some people who have come back because the nasal spray is FDA approved as a BID dosing regimen. I've had patients come back saying, I know you said I need to wait 12 hours or twice a day, but I feel when it wears off at about 8 to 9 hours. Can I take another spray then? I said, yeah, absolutely, 100%. So again, they didn't want to take that nasal spray until they saw me. There's also evidence now that shows that things like IPL actually have some benefits with neuropathic patients. And I think this is partially starting to take the skin and the surrounding tissues into consideration with these patients, attempting to reduce inflammation, and over time, that providing less of a chronic stimulation of that nerve ending in the cornea that will ultimately dampen the central perception of this pain. So again, there's all of these things that we're starting to see, and there's some trends, but I still think at the end of the day, we need those individuals or those companies that are willing to say, we want to study this more aggressively. We want to make sure that we're looking at this in a more controlled way to determine if, in fact, there really is some clinical benefit to this. And it's not just colleagues like us sharing ideas. And that's when we're ultimately going to start finding better pathways to more consistent treatment options for these patients.
It's going to be really cool to see in 5 years, 10 years, right? So much more that we're going to know about these little nuances. So that's why I sometimes love these podcasts as like a timestamp because we can look back. Things, innovation happens so gradually that you kind of sometimes forget where you come from, and so it's going to be really interesting to see where we land with that.
Jessilin, to that point, there was a lecture in 2003 that I saw, a pretty prominent lecturer who had commented at the time that, yeah, before we had automated visual fields, and I thought, oh my gosh, before we had automated visual fields. Well, in my career lifetime, I graduated in 2002. We came the first year that I was in practice, the first commercially available OCT came out. That was time domain. And in 2006, spectral domain, which we now know, came out. So I can now say that same thing for the one piece of equipment in our practices that we all take for granted. How could you practice without an OCT? I think to myself now, but we did it at one point, and we did it as best as we possibly could at the time. So I'm now communicating about OCT the way that this lecture actually communicated about automated visual fields. It's wild.
So true, so true. All right, to do a little bit of a recap. So we've kind of touched on EBMD, floppy eyelid syndrome, neurotrophic keratitis, Demodex blepharitis, kind of this neuro dry eye. Any other like heavy hitters or common masqueraders that you see outside of those conditions?
Yep, a few. So we talked about incomplete lid seal. I think it's important to identify that. I do still think that the curiosity in us, the clinician, is important. And what I mean by that is high magnified views of the ocular surface, especially the lid margin. You can't imagine how many times these people come in, and then when you question them about their dryness, they say, no, it's just this eye and it's just this spot. And when you look very closely at that lid and or that eye and that spot, there's oftentimes a trichiasis, a subtle um, eyelash coming out of the meibomian gland. So those are things that we need to be cognizant of. Neurotrophic keratitis is a biggie, and we need to be on the prowl for that. We need to make sure that we're testing corneal sensitivity. As much as we're talking about neuropathic pain, a dullness of that corneal sensation is important as well too. Mucus fishing syndrome. Literally nothing wrong with that patient's eye other than them trying to constantly clear the mucus out of their eyes. Things like much less common but important to identify advancing wave-like epitheliopathy, which when detected, we need to make sure and try and figure out clinically what's causing that pattern to occur and how we can eliminate it from the patient's real regimen to make sure that we're treating them as opposed to adding something else. And then allergic eye disease is one that we didn't talk about that can very closely mimic those symptoms of dryness if we're not looking at them carefully. And in the next several years, we will see diagnostic tests that are going to be available that are going to give us the ability to differentiate that. There was one that was recently available measuring lactoferrin and IgE levels, but that has now become unavailable, unfortunately. But over the next several years, we hope that there'll be new platforms that'll actually deliver our ability to be able to differentiate those.
What a great recap. Thank you for kind of going through all of these things. I think we all, as soon as you say it, we're like, oh, yes, right. Of course, that one. Yes. Oh, right. That one. So, but it's helpful to have a nice little, top of mind. So when we see our patients tomorrow or later today, if we're listening to this in the morning, I think, oh, yeah, I should really actually make sure I'm ruling out EBMD and looking closely for that. So thank you for doing like a great review on all these potential misleading things that can lead us down the wrong path. One thing I want to ask you, and we always end our podcast with what our guest's life lens is. So this one thing that is in your life that doesn't have to be optometry related, but is very useful. You find it a game changer in your life and something that's made your life a little easier. Do you have something like that in your life?
Actually, I'll go one step further. So, in the profession of optometry, you're always wondering, like, and especially if you're a practice owner, but certainly even if you're kind of walking in and you're employed by somebody else, you're always wondering how you can refine your skill set and just make it sharper. And even if you have hobbies that you're passionate about, you're doing that same thing. So my lifeline is to truly ask yourself to try and never stop asking questions about whatever you're pursuing. Because the moment you stop asking questions, the moment you just take for granted what you're doing, the moment you just get into a regimen and stop re-questioning and re-questioning, that truly is the spot where you've lost the passion for what you're doing. And you either need to do one of two things: take a little bit of a break, whether that be a day break or a vacation or just a tonight, I'm not going to think about anything and I just need to recharge the batteries, or it's time to stop practicing or doing whatever that thing was, because that is truly the place where professional growth happens. As soon as we think we've mastered everything, we're done. Our patients are going to lose out, and they feel that from us as well too. So again, my lifeline is to never stop asking questions, and the moment I do is the moment I realize maybe now I'm kind of done with this path in my life, and maybe there's something else that I need to pursue. But fortunately, at this point, I'm still asking those questions and still enjoying asking those questions.
Well, Mile, I would say your eagerness to learn is contagious. So
It
thank you so
is.
much for being here with us, doing this podcast, for just contributing to our profession as a whole. You do so much to better eye care, and we are all so appreciative to be a colleague of yours. If our listeners wanted to connect with you outside of this To the Point podcast, you're also a podcaster, or do you have any socials or an email that you want to share, or how could people find you to follow up and connect with you?
Yeah, well, certainly to both of you, thank you. I've been watching both of you from very early on in your careers, and what you guys are doing is just absolutely fantastic. So every time I see anything that has your name on a publication and or your name on a podcast and or your name on anything, I just know that it's going to be accompanied with quality. So keep doing what you guys are doing because it's not going unnoticed. People are seeing you, and you're valued assets to the profession. So I own a company with Dr. Kading where we do a lot of education called Optometric Insights. You can follow us on our social channels as well too. You can email me at mila@optometricinsights.com as well too. That's always a place where you can reach us. And we actually have a I know we were talking a lot about what's not dry eye today, but we have a pretty big partnership this year with Woo U, where we're going to be talking about the CLOSE program, Collaborative Learning and Ocular Surface Education. It's going to be a whole year-long process where we're going to be talking about dry eye. And for those that are interested in incorporating a more active process in their practice, how to actually do that through kind of a coaching philosophy. So we're super excited about it.
That's awesome. Mila, you're the best teacher. You really are. And you know what else is you're like the calmest. Like, don't you just feel calm listening to him, Jessilin? Like anytime I'm in any meeting with you, I'm like, man, you're the always the calm, the voice of reason. Like, ugh, what a great quality. Thank you for being here.
Jackie, if you ever want to have lunch or dinner with my wife, it's covered. Just share with her exactly what you just
I love
Thank
it.
you again. Thanks, Mila, for being here. We so appreciate you spending time with us. Thanks so much.
Thank you both.